A 63-year-old female presented with complaint of locking sensation and pain in her left knee during knee flexion after falling. Findings from the physical examination and magnetic resonance imaging led to a diagnosis of a radial tear in the midbody of the left lateral meniscus. After routine arthroscopic evaluation, the posterior portion of the lateral meniscus was easily pulled through the lateral condyle with a probe, and the obvious midbody of the lateral meniscus was observed from the anterolateral portal. Rasping was performed to refresh the end of the torn lateral meniscus. Extreme caution is required not to injure the meniscus midbody and cartilage. A throated cannula was inserted through the anteromedial portal with the tibia maintained in birth and internal rotation, resulting in the figure 4 position. The throated cannula was then positioned above and below the peripheral region of the lateral meniscus to hold it. We used the all-inside tie grip suture technique with tool span to restore the hoop structure without insiding the lateral knee. 2 stitch sutures were placed vertically, and 2 suture loops were placed horizontally. Vertical sutures were placed as grips to prevent cutting and slipping of the succeeding horizontal suture. First, 2 vertical sutures are placed. A threaded cannula is inserted through the anteromedial portal and far anteromedial portal when needed so that tool span can be easily inserted. The built-in adjustable depth penetration limiter was set at 14 to 16 mm. The deployment handle is pulled to deploy the first implant at the proximal side of LM. The delivery needle is then pulled slightly and rotated so that its tip aims slightly at the capsular side where the second implant is placed. In case a defect remains between the torn edge of the radial tear of the meniscus after placing 2 vertical sutures, a fibrin cord is introduced into the defect, and horizontal sutures are performed to pull the torn edge close. Care must be taken not to damage the meniscus or cartilage during these procedures and to ensure that the sutures do not interfere with the LCL. The location of the LCL can be examined by palpation it from the outside of the knee joint. Diagnostic probing is performed to evaluate the stability of tie grip sutures. The patient was immobilized for 4 weeks after surgery, and range of motion exercise and weight bearing as tolerated were allowed after immobilization. The patient recovered to the preoperative activity level 6 months after surgery, with no recurrence during the 2-year follow-up.